Assalamu alaikum. Good morning to everybody for Bangladesh and good evening on the western globe of the world. Today I welcome you all to the second interesting case presenting symposium. We have completed last month the first case presentation, and today we have Dr. Rafiq Ahmed as our chief guest, and the meeting will be chaired by Dr. A.P.M. Sohrab-ul-Jaman. And we have 5 presenters today: Dr. Anindo Ghosh, Dr. Shamim Chaudhary, Dr. Umme Habiba Firdausi, and Dr. Musaddiq Hussain Sadi. So I first would ask Dr. Sohrab-ul-Jaman to start the program. Sir.
Assalamu alaikum. Good morning, good afternoon, and good evening to everybody. This is Bangladesh Horticultural Society has arranged 2 consecutive interesting case presentation. Today is the second session. We have our very respected and honorable teacher, mentor, Dr. Rafiq Ahmed as our chief guest and the principal discussant of the cases. Let us start with our program. Thanks.
Thank you very much. I would ask Dr. Professor Atahar Ali to say a few words.
Thanks, Dr. Zamil, for organizing and doing everything for the session, and we are very much proud to have our Dr. Rafiq Ahmed sir, the founder and pioneer of electrophysiology Bangladesh, as our chief guest in this session. And we are happy to introduce all the participants as before the last sessions. So, Dr. Zamil, you can start the program without any delay. Thank you very much for your invitation.
Now I ask Dr. Asif Jaman Tushar to moderate the session. Please, Tushar. Tushar. Probably he is not in the line.
Sir, there is some problem in my internet connection.
Okay.
I can't get to the video.
Continue.
Okay. Now I ask Dr. Anindo Ghosh to start his presentation. Dr. Anindo Ghosh.
Good morning, sir. I'll share my screen, sir. Sir, is my screen visible?
Yes.
Yes. Good morning, everyone. At the very beginning, I would like to express my utmost thanks for having me again in this prestigious session to present an interesting case. I'll be discussing a case on a patient with the conduction system disease and some interesting findings which we found at the time of the electrophysiology study. My case is of a 68-year-old female who is diabetic, who is hypertensive, who is a known case of non-ischemic dilated cardiomyopathy with an ejection fraction of 33%, global hypokinesia, and the LV is also quite dilated. She presented to us with complaints of palpitations for 6 months and 1 episode of syncope. Her medical history, treatment history revealed that she was on guideline-directed medical therapy with ARNI, SGLT2 inhibitors, and mineral corticoid receptor antagonists. And there were no rate-controlled medications like a beta blocker or a calcium channel blocker in her prescription. We got a 12-lead ECG. The 12-lead ECG was showing a sinus rhythm with a very prolonged PR of around 230 milliseconds. There was changing P wave morphology, so we cannot say whether it's sinus or not. There is right bundle branch block with a leftward axis, suggesting that there is a left anterior hemiblock too. At different periods of time, the patient had different ECG manifestations. As seen in this second ECG, 12-lead ECG of the same patient, we can see most of the time the patient's P waves are of sinus morphology. However, there intermittently comes some atrial ectopy, which is of a different P wave morphology. All in all, based on the two ECGs, the patient seems to have significant intrahesian conduction system disease. And combined with a history of syncope, most probably it's a bradyarrhythmia. However, the patient has non-ischemic cardiomyopathy too, so a possibility of a ventricular arrhythmia precipitating syncope and palpitations was also kept in mind. So, from the surface ECG, what we got was a changing P wave morphology, a PR which was also changing, but with a wide QRS, RBBB, left anterior fascicular block. Also, if you see deeply into this ECG, we can see some interesting patterns of periodicity. These two P waves, these two QRSs, alternating QRSs, couplets, they seem to be coming in regular intervals. The cause of which at that time we didn't know, but which we ultimately subsequently found out at the time of the EP study. We also did a Holter, 24 hours Holter for this patient, where we found that there were periods of Wenckebach periodicity. It looked like typical Wenckebach in that there was gradual prolongation of the PR and the subsequent RR intervals. You can see the third RR interval before the block is, if you can see very closely, I've marked all the three markers here. The third RR interval is the shortest. So in a typical Wenckebach, subsequent RR intervals keep shortening before the block. This seems quite paradoxical, but this is a definition of a typical Wenckebach. The P wave, although cannot be commented on a Holter tracing, but seem to be of a constant origin. So we took the patient for an EP study. And when we initially placed the catheter, which was a His bundle catheter, quadripolar, we got this tracing. At the beginning, from the surface 12-lead ECG, on top of the trace, we can see that there is a bifascicular block, as can be inferred from the complete RBBB and a left axis deviation. The P waves look to be superiorly directed. They are negative in inferior leads, 2, 3, and AVF. So they are superiorly directed and probably not of a sinus origin. If you come down to the intracardiac His signals, this points to 3 distinct electrograms. So you can see 2 smaller ones and one big one. The third EGM, which is, we'll go slow on this trace. The third EGM, which corresponds to the surface QRS, which is of larger amplitude and corresponds to the surface QRS every time, is obviously the ventricular EGM. Now the question comes as to what are the first 2 signals. It would seem natural to consider them as A, H, and then the V. However, what we note consistently throughout is the first and second EGMs have a constant relationship 1, and the second of these EGMs, which I am pointing with my pointer, the second of these EGMs correspond to the surface P wave. If you note, every second EGM corresponds to the surface P waves. Moreover, they are seen on both the proximal and distal His electrodes everywhere. So we can reliably say that this second EGM is the atrial EGM. Hence, the first EGM, which is recorded only on the distal pair of His electrodes, is the His signal. We can see here that the HH intervals and HA intervals both are constant. However, there is a progressive prolongation of the HV interval, as is shown by these arrows, until The third H blocks either within the his or below the level of his, suggesting a 3:2 AV Wenckebach. This is shown in this ladder diagram. There is the atrium, AV node, his in the ventricle. So our inference was that there was a Hisian escape, an automatic escape rhythm from within the his, which was conducting retrogradely 1:1 to the atrium, however blocking into the ventricles in a 3:2 Wenckebach fashion. We can see the HH intervals 763 milliseconds are constant. So are the AA intervals, which corresponds to the HH, because the HH is constantly connected to the atrium retrograde conduction, and hence these two intervals are constant. However, there is a progressive prolongation of the HV intervals. There were periods when this kind of rhythm, again we see on the surface ECG 2-3 AVF negative. So these are retrograde P waves. We can see the 3 electrograms, but there were some instances when this used to conduct 1:1 throughout. On the surface, it may look like an ectopic atrial rhythm with a prolonged PR, but what we see inside is that the entire rhythm is being driven by the Hisian escape automatic focus with a very, very long HV. As we continued the EP study, these are the annotations for the same signals on the surface P waves and the intracardiac EGMs, signifying the HA intervals are constant by these double-headed red lines. As we continued the EP study, the native sinus rhythm overtook the Hisian automatic focus. How do we know that? You can see in AVF, the P waves were inverted previously as superiorly directed, which we saw from the previous electrograms. We saw this to be a retrogradely conducted A wave. However, on the right side, we can see that the sinus rhythm has taken over, as is shown by the upright P waves in inferior leaves. So, when this native atrial rhythm, sinus atrial rhythm, overtakes the Hisian automatic focus, as can be inferred from the changed P wave morphology, the HA association is lost. On the left side of the screen, you can see constant HA as we were getting from the previous EGMs too. But when the sinus rhythm took over, obviously the sinus rhythm was competing with the Hisian focus. So the HA intervals, this is HA, HA is fused here, almost fused here, fused everywhere, and then coming out. So this HA, there was an HA dissociation, which ultimately culminated on the surface ECG with a AV dissociation. We can see the A is nowhere related to the QRS. However, there is still an interesting pattern of HV of a atrioventricular Wenckebach on the surface ECG. We can, if we are given only the surface ECG, we may think that this is AV nodal Wenckebach with a drop on the fourth beat, that is a 4:3 Wenckebach. But what we see here is even when the sinus rhythm takes over, the ventricle is not driven by the H, as is seen in this ladder diagram. There is an AV dissociation, which is driven by a sinus rhythm, which is competing with the Hisian escape almost at the same interval. We can see the HH intervals and HA intervals are fairly competing with each other. There is a collision of both signals, either in the AV node, which is being either antigradely depolarized by the sinus P wave or retrogradely depolarized by the Hisian focus. However, what is constant is there is a prolongation of HV interval followed by a block, this time in a 4:3 fashion. So we see here in this ECG where the sinus rhythm P waves keep coming. However, the PR intervals keep changing. That is because the ventricular rhythm is not being driven by the atrial with sinus P waves. This is being driven by the Hisian escape rhythm. Now, Wenckebach periodicity has been classically mentioned as an AV nodal phenomena, not an intra-Hisian phenomena. So, intra-Hisian Wenckebach is a rare entity, and has been scarcely reported in literature, although it may occur more commonly because we don't do an EP study routinely in every patient with bradyarrhythmia. The distinction sometimes becomes critical because a Wenckebach at the level of AV node may be overlooked. However, an infraesion Wenckebach is a harbinger of a complete AV block and requires permanent pacing, contrary to the AV nodal Wenckebach. In our patient who had an ischemic cardiomyopathy, ventricular arrhythmia was also kept in mind. Ventricular induction protocols revealed nothing. We also did a cardiac MRI to rule out inflammatory and infiltrative pathologies, which were normal. So, in short, our case demonstrates an intracardiac electrogram in a patient with infrahesian conduction disease, revealing an intriguing phenomena of a Hesian automaticity with varying patterns of infrahesian Wenckebach on alternating instances of retrograde atrial activation and VA block. Thank you.
Thank you, Dr. Anindo, for your nice presentation. Now the case can be discussed.
Dr. Anindo, thank you very much for your excellent case presentation. Really, it is an exceptional case and outstanding presentation. So, Anindo, I want to know what was the actually 1:1 AV conduction? What is the quality of the AV conduction, anti-grade AV conduction?
Sir, during EP study, we never got an anti-grade AV conduction. What seemed on the surface ECG to be anti-grade AV conduction was never driven by the sinus P waves. It was always by the Hesian escape. We conducted the EP study for nearly 1.5 hours, and there was never a time when the A got conducted to the ventricle. However, we paced the atrium at a higher rate to see AV conduction. That time we got a 2:1 at a higher rate. But spontaneously, when the patient was being subjected to the EP study, there was never a time when the atrial rhythm was driving the ventricle. Always there was this Hesian focus which conducted either 1:1 to the atrium, or there was an HA dissociation because the atrial rhythm used to compete with the Hesian rhythm, and the ventricle was always being driven by the Hesian rhythm, sir.
But Anindo, I like to, Ganesh, ask you actually, in one ECG, what you have shown, when the PFs are upright, not, that is the inferior axis, in that case, there was type 1 Mobius block, AV block.
Sir, I'll go to the ECG, sir. Okay.
I see.
Sir, which one, sir?
In this ECG, not in that one, previous. Here.
Yes, sir.
Here you can see in the middle, the 3 bits.
Yes, sir.
Short PR interval, getting prolonged, then AV block.
Sir, actually on the surface ECG, if you see, it looks like a PR prolongation, PR block.
It looks like.
Yes, sir. But what we see in the intracardiac traces is that this is the AA wave, sir. This PR is not physiological for this patient. This is too close to the QRS. So this P cannot conduct to this ventricle.
No, his is earlier.
His is earlier, yes.
And getting fusion. He's an AR getting fusion.
Yes, sir. He's an AR getting fused, yes, sir. Yes. So this is the ladder diagram, sir. Every time the atrium tries to get down, there a Hesian focus is just competing at the same time, and the collision is either at the level of AV node, which is getting depolarized either by the we cannot measure the AV nodal signals, no, sir. So it is either antigradely depolarized by the atrium or retrogradely by the Hesian focus. We don't know, sir. We have postulated that it could happen anywhere here. But what we is confirmed that this H is getting conducted down, and it is actually an HA dissociation, sir, which culminates on the surface ECG as a AV dissociation, because even if it looks like a PR prolongation at block, the first PR is like a pre-excited QRS. This is not possible in a patient in this scenario. This PR is too short, sir.
Now, this is a brainstorming case.
Yes.
I agree.
I think this is a very interesting case. Thank you.
Thank you.
And we recently had a case. I mean, this case, even if there was no AV block, you would probably have put ICD in because of,
Yes,
but
sir.
our case that we had a patient with syncope, and what it looked like Wenkeba.
Yes.
And out of curiosity, we did EP study. Normally, we don't do EP study in this center, and we found the same phenomena of infrahis Wenkeba.
Yes.
And then patient will develop infrahis 2 to 1 heart block, and patient ended up needing pacemaker. And as Ananda mentioned, that we don't see many cases, but I think the reason is that in the old days, we used to do EP study in a lot of these patients. Nowadays, we don't.
Yes, sir. Yes.
We don't do many EP studies for bad arrhythmia. That's why we don't see it. But it's a very, I mean, what is the importance of this case is to understand the physiology and the thinking process. And what happened in these tracings, we had only 2 his channel. If we had another one,
yes, sir,
without the A, just the his, you could have seen it much better.
Yes,
when the P, his got buried in the P wave,
yes,
you had to imagine the his. But if we had another electrode, then we could have probably seen it better because 3 and 4 is in the atrium.
Yes, yes.
No question. Great case. Thank you.
So actually, we don't do EP study for, as you said, infrahis in Wenckebach may be more common than we know. And what is the classical teaching is it is a AV nodal phenomena may not be true, sir. But with conduction system pacing coming on, sir, we may do more EP studies in cases, and this phenomena may come out slowly. Sir.
Sure.
Thank you, sir.
Dr. Mohsin, would you like to put a comment? Dr. Mohsin.
আমি ব্যস্ত আছি একটু আমি ব্যস্ত আছি
Jamil, Mohsin is busy with otherwise.
Okay.
So leave him, he will be joining when he is complete his work.
Okay, sir. Okay. Palash.
Sir. Good morning, everybody. So I think that this is a very interesting case presented by Dr. Anindo because the infrasian block is not commonly seen and commonly practiced in our EP lab also. We are not doing the bradyarrhythmia patient to do the EP study to find out what is the block level. So it is very interesting to learn, everybody. Thank you, Dr. Anindo.
Thank you, sir.
Dr. Mustadakar Saadu, would you like to say something? Please unmute. Please. Sorry, right.
Yes, presented nicely, though it is not common, but we understand the thing. In future, we may take a guide from this case.
Jamil, next presenter.
Next presenter, Dr. Shamim Chaudhary. Please go ahead. Shamim.
Yes, sir. Honorable Chairperson, respected moderator and panel of experts, Assalamu alaikum. I am going to present a case of my mentor, Professor Mir Naseeruddin Ahmed. Title of my case is The Hurdle to Reach the Destination. My patient, Mrs. X, 35 years lady with a history of CRTP implantation in the November 2020 due to non-ischemic dilated cardiomyopathy with a LVB morphology with sinus rhythm with shortness of breath of NYHA class 3. Now presented to us on 24th August with the complaints of shortness of breath of NYHA class 2 to 3 and followed by tiredness and palpitations. On query, she gave history of LV lead dislodgement on third period of CRTP implantation during her admission. In this period of time, she gave no history of vomiting or extraneous activity or any illness between this period. This is her ECG on 24th August of this admission. It shows there is a LVB morphology, however, there is a pacing of the LV leads are missing, and with there is also left axis deviation. QRS complexes are white. And we did the chest X-ray, which showed the LV lead is displaced and it is circled in the looped in the array with the tip just residing on the coronary sinus. We did routine investigations that showed nothing abnormality. We did echocardiography that showed LV cavity was dilated with severe global LV systolic dysfunction with ejection fraction 28%, traced to mild mitral regurgitation with traced trigastric regurgitation with mild with pulmonary arterial systolic pressure 30 millimeter of mercury with fair RV systolic function, and there were grade 2 diastolic dysfunction. This was her first ECG before CRT implantation on December 2020, which showed the LVV morphology with sinus rhythm with QRS duration around 150 milliseconds. And this is her. This was her ECG just before discharge that shows narrow QRS complex with the both LV and RB pacings and positive QRS and 2,3 APF. And we plan to reposition the LV lead. We checked by fluoroscopy, and it also showed the lead is displaced and it is looped in the array and tip residing in the coronary sinus. We again punctured and the CS LV lead was removed easily, and we put an wire and put a long sheet through the wire, and we tried to cannulate the coronary sinus again by a PTCA guide wire, but we failed to access the cannulate the coronary sinus. Followed by we take the help of the CS catheter to cannulate the coronary sinus, and followed by we position the sheet to do a coronary sinogram or sinus angiogram to show. The coronary sinus angiogram. Followed by that, we position the catheter, and we just give the coronary PTCA wire to cannulate the coronary sinus. In that case, we showed that there is no posterolateral vein was identified, and we tried to access into the middle cardiac vein. We give the LV lead to the middle cardiac vein. As there is the mismatch between the lead diameter and the vein diameter, this is the second episode of the patient of lead displacement. We try to fix it up. We put another wire through inside beside the LV lead, and took an 4 to 16 millimeter stent, and after dilatation of 8 atmospheric pressure dilatation, we pull back and again dilated up to 12 to 16 millimeter 16 atmospheric pressure to fix the lead in the proximal portion of the LV lead. Stent was deployed. After that, wire was removed, and this is the final result with the stent in situ in the proximal portion of the LV lead. And after several traction, we saw that the lead is stabilized. And this is the ECG after repositioning of the CRTP, and it shows the QRS morphology around 130 millisecond, and both LV and RV pacing. This is the ECG of the patient on first follow-up after 15 days, which showing the QRS morphology around 125 to 30 millisecond with both LV and RB pacing. Now, in spite of improvements in the lead design and delivery system, incidence of intraoperative and postoperative lead displacement are seen in 2 to 12% cases, leading to the loss of LV capture and undesirable stimulation. The use of coronary stent technique has been proposed an alternate method for stabilization of the LV lead in patients who experience repeated dislocation. First case report of a coronary stent to stabilize the lead in the coronary sinus was published by Cesario et al. In 2006. Several studies conducted that the lead stabilization by stenting based on coronary vein anatomy can effectively reduce lead dislodgement rate from 10% to 1%, and lead performance was unaffected by the stenting procedure. This was the last case report that was published in 2019 in India, where just after during the procedure, lead was displaced several times. So in conclusion, stent implantation to stabilize the left ventricular lead position seems to be a useful and safe procedure in the treatment of patients with complicated coronary sinus anatomy or lead instability. Thank you all for your patient hearing. This is the picture of our cath lab.
Thank you, Dr. Shamin Chaudhary, for excellent case deliberation. Now I would ask me Nasaruddin Ahmed.
Jamil bhai,
Yes.
just
It is his case, Jamil.
Yes.
It is.
Jamil bhai,
I think Nesar should tell after the.
I think it will be discussed from the Professor Atar sir and the Rofik sir and other faculty also. Yes, because I've already discussed in the last session with the Rofik sir, what can we do for this patient, as because patient has come after 9 months with the dislodgement. And considering the anatomy, there is a vein, it's a bit larger for anchoring the screwing lead. That's why we are thinking about for placement of the diameter stents in this case. But this discussion should come from other faculties, especially Rofik sir, Atar sir, and others. Saurabh sir, please comment on this case.
In between, I want to mention one thing. Dr. Anindya Ghosh has put a message. He has to leave for an emergency case. So thank you very much, Anindya.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, Anindya.
Thank you.
Thank you for a nice case.
Thanks.
Nice academic case.
Thanks.
Thank you.
Saurabh sir.
Nessa, you have put the stent in the coronary sinus and almost near the ostium.
No,
What was
not
that?
in the coronary sinus. It was in the posterior middle cardiac vein, just on the just terminal end portion of the lead, not in the coronary sinus.
I think that middle cardiac vein is near to the coronary ostium also.
Yeah,
Near, most likely.
but we try to place the lead as far as possible to the lateral aspects, where we can get the proper signals and proper programming features.
What,
then we
what
place
was the size of the stent?
lead, and then 4 millimeter, 4 into 16 millimeter.
4. Diameter was 4.
Diameter is 4.
Diameters were 4.
Yeah,
Because the veins are always expandable and very flexible, you know. And the veins are very dilated. The big size stents are very rarely available.
Yeah.
So it is in the middle cardiac vein and near to the bifurcation, I think. And that middle cardiac vein
sir, this is not just as far as the point.
Show that slide.
Distal end of
you can
the
show that slide, please.
slide, please.
Sorry.
Distal end of the lead, not in the proximal end, not in the coronary sinus os. The stent was placed in the distal end of the
I have
lead.
one query regarding how we should stent to gel the LV lead. I think that should not cross.
We place the wire second another wire across beside the LV lead. Then we place the stent over the wire and ultimately fix the stent to just press the lead, and then we pull out the PTC wire lead. PTC wire.
Yes, sir. Yes, sir. Your stent has covered proximal two pole of electrodes of the lid.
That is the important thing.
Yeah, yeah,
Is it,
yeah.
is it going to
Yeah,
impair?
here is the lead. Yeah,
Two pole will act as a
coming to the
single
cow.
pole. If it
This two
touches two
pole
poles,
might have
it will
impaired
act as a
function.
single pole.
Yeah. It became not quadripolar, now it is bipolar. Like that.
No, no,
No?
no, no.
Actually, that after post dilatation,
We have checked all the parameters after
Okay.
post dilatation.
does it touches both the proximal poles?
It covers almost.
Just see.
Yes.
That we can see. It is on the
So,
proximal two poles.
Surabajaman sir, actually that is far away from the coronary sinus ostium, that is within the middle cardiac vein. Now I have one query regarding if it touches the two poles, if the stent one is touching the third pole and other end touching the fourth pole, does it produce any problem in that is quadripolar will become tripolar like this?
Tripolar now. Yes. That's a possibility.
You want to comment from the Rafik sir?
It's metal and it's covering both the poles. Connecting.
Before thinking the placement of the stand, we have read about the different literature, how to place, how can we place the stand, and how can we measure the parameters for the CRT. Yeah, anyway, I just want to comment from the Rafik sir.
Actually, I was that time I was there. That was very much difficult cases. That was very much difficult case, and that takes long time.
Yeah.
And it was very much difficult to approach the posterolateral vein because of its angulation, and that was very much small vein.
As because first time we placed the lead over there, and this time as because the dislodgement of the lead, we cannot find the posterolateral vein again.
Yeah.
Rafik sir.
Yeah. Quick. I mean, one comment is I'll come to, as far as the stent position is concerned, the electrode number 2, 3, 4 in this patient is totally useless because these are inferior. So only electrode from CRT pacing standpoint that count is the distal electrode, because rest of them are inferior. And if you pace from them, you'll basically pacing the RV. So that's not an issue. The issue is just clinical question. Before the BIV was placed, how long was the patient treated with medication?
So patient was around 1 year, and he was concerned with the other hospitals, and ultimately come to the hospital.
And maximized medical treatment,
yeah,
right?
Yes, sir. You're getting all this medication, including ARNI. Everything.
Sure. Yeah, I mean, you had no choice. I mean, here you preempted it with a stent, because the fact that the other lead dislodged doesn't mean that it would have dislodged from this place.
Yeah.
So it's a preemptive action.
Yeah.
We don't do stent only because in a 35-year-old, if the lead fractures, it will be a nightmare to extract this lead.
Yes, sir.
So we have not done it at all. If the lead dislodges, we use the Medtronic, the active fixation lead. It's pretty good especially for larger veins, because we can rotate it. So it's a good technology to learn, but I hope that you use it infrequently.
Yes,
that will be my only request. Thank you.
So could it be possible to have active fixation lead for a larger vein?
That's what it is designed. The only problem of active fixation lead is if the tip is wedged up,
yes,
then because when you do this Medtronic active fixation lead, the whole lead must rotate. So if the tip is wedged against a narrow vein, the body will not rotate. So you will screw it. As soon as you take the finger off, it coils back. So if you are using that Medtronic active fixation, please make sure that you do not push the lead as far as possible. keep a little behind the teeth, so that, and I magnify the fluoro so that I can see everything moving. That will be the best way to do it. Even then you will see some recoil, and then when it recoils, I want to make sure with tugging that you pull back, and because you cannot push it in, you have to pull back a little bit to see if it comes out. That's the only way. And I think initially I did not like the concept at all, but in difficult cases, it has really proven to be useful, this Medtronic active fixation lead. And injury-wise, my main concern was injury. You cannot injure the vein because the lead is soft enough that even if you over-torque it, it will not tear the vein. So it is safe, actually. Thank you.
Thank you, sir. Very nice comment.
And I like the position of the RV lead, because that's a septal position, and that's what we should be done for BiVs. All leads should be placed in the septum if possible at all.
Yes, sir.
Sir, may I ask any questions, sir?
Now I ask Dr. Habiba Firdausi to present her case. Firdausi. Unmute. Firdausi, you are muted.
Share screen.
Share your screen.
The options are put to me.
Go to the bottom panel. Put your cursor on the green up arrow. Share screen. Click it.
Yes. Sure.
Okay. Go to the slideshow mode at the bottom of your PowerPoint presentation. Okay, thank you.
First of all, Assalamu alaikum. I'm Dr. Habiba Firdausi, Junior Consultant in ICBD. First of all, I want to express my humble gratitude to the Honorable Chief Guest Chairperson and respected panelists and my teachers for giving me the opportunity to present in this prestigious forum of Bangladesh Heart Rhythm Society. My today's topic entitled Septal or Apical Pacing. ECG can unveil the enigma. It's not moving. So this is my first case. A 60 years old female presented with recurrent syncope 3 times last year with paroxysmal palpitation, occasional dizziness, and weakness. Baseline ECG was normal, and 24-hour Holter monitoring shows minimal heart rate, about 18 beat per minute at 4 p.m. A number of pause more than 2.5 seconds 2 times in daytime, and 1 episode of atrial fibrillation noted. Echocardiography shows structurally and functionally normal heart. So this is the reports of Holter monitoring, and the diagnosis was 6 sinus syndrome. So permanent pacemaker implantation. In the left panel, that this is the fluoroscopic view. LAO30 shows dual chamber pacemaker with RV upper septal pacing and RA pacing. And here is the pacing ECG, and post pacing ECG shows A pace and B pace with narrow pacing QRS about 88 milliseconds. And this is my second case with a 72 years old male presented with syncope. Baseline ECG shows complete heart block with ventricular escape rhythm is complete RBB morphology. And echo shows structurally and functionally normal heart. The diagnosis was degenerative complete heart block. So we implant permanent pacemaker. And these are the fluoroscopic view in REO, LEO, 30, and left lateral view. And here is the post-pacing ECG. Show the RV upper septal pacing, and pacing QRS duration is about 142 milliseconds. And this is another case. 70 years old male presented with syncope. Baseline ECG shows complete heart block with ventricular escape is RVB morphology. And echo again shows structure in function normal heart. And this is also a case of degenerative complete heart block. Echo was normal and permanent pacemaker implantation done. And this is the fluoroscopic view of a single chamber pacemaker RV apical lead positioning. And the post-pacing ECG, this shows ventricular pace with underlying rhythm is complete heart block, and with the wide pacing QRS about 184 milliseconds. So if we compare these three ECG, in the upper panel, both are septal pacing ECG, and first one is a very narrow QRS complex, pacing QRS complex, about 88 milliseconds. Second is a little bit wider, 142 milliseconds, and third one is a case of apical pacing with a QRS is wide, 184 milliseconds. So several studies have demonstrated that conventional right ventricular apical pacing causes changes of the electrical and mechanical activation pattern of heart. So these changes can result in an altered regional perfusion, mechanical desynchrony, and advanced left ventricular remodeling. Now, how these changes occur? Spacing from right ventricular apex, a different muscle strain and fiber shortening occur, an abnormal late activation of the lateral wall of the left ventricle, which causes desynchrony, and which in turn increases myocardial work and oxygen consumption. So altered regional wall motion perfusion. So these changes in cardiac hemodynamic causes the ventricular cellular abnormalities both at a gross and ultrastructural level. So may lead to left ventricular remodeling. These adverse effects are associated with a high risk of development of LV systolic dysfunction, heart failure, and atrial fibrillation. So here is a study showing long-term effect of right ventricular pacing on myocardial perfusion and function. They studied 43 patients with complete heart block and dual chamber rate adaptive apical pacing. They underwent thallium scanning to assess the myocardial perfusion and radionuclide ventricography to determine left ventricular function and regional wall motion. They also did the coronary angiography to the patients who developed myocardial perfusion defect. And the mean duration of the study was about 3.5 years. So after 3.5 years, the long-term RV apical pacing resulted high incidence of myocardial perfusion defect, and which increased with the duration of pacing. And in this bar diagram, we can see those patients who developed myocardial perfusion defect significantly reduced ejection fraction. And in thallium scanning, they showed regional wall motion abnormality in the patient who developed perfusion defect, and the apical wall motion abnormality, and in general total LV wall motion abnormality was there. And they also did perfusion defect association with angiogram, and angiogram showed only 3 patients was critically significant coronary artery disease. So these perfusion abnormalities observed also cannot be totally accounted for the presence of underlying coronary artery disease. So another study showed cycle tracking radial strain, which reveals the ventricular desynchrony in patients with permanent RV pacing. So 58 patients were treated with his bundle ablation and pacemaker implantation studied, and they studied for about 5 years of RV pacing. And they showed at baseline similar time to peak strain for 6 segments was observed, but after 5 years, they showed marked heterogeneity in time to peak strain of the 6 segment. So 33 patients, that is 57% patient develop LV dysynchrony, which is represented by a time difference of more than 150 milliseconds. And these patients also develop a deterioration of the systolic function and NYT functional class. And in 11 patients, an upgrade of conventional pacemaker to biventricular pacemaker required. Previous two studies, David and most studies showed that those patients with RV apical pacing, the risk of death and heart failure or hospitalization is significant. And most studies showed that a cumulative percent ventricular pacing was a strong predictor of heart failure hospitalization. So the aforementioned studies suggest that RV apical pacing should be avoided. But in these two studies, David and most, the exact mechanism of this detrimental effect of RV apical pacing remain unclear. But this spectacular study shows that decrease in the LV systolic function and NYT function class is directly related to the presence of LV dysynchrony. And this is a landmark trial of predict heart failure, which shows paced QRS duration as a predictor for clinical heart failure event during right ventricular apical pacing. So they studied 194 patients and stratified them in three groups. Paced QRS duration less than 160, and group 2 QRS duration within 160 to 190, and group 3 paced QRS duration more than 190 milliseconds. And during the 3-year follow-up, the incidence of heart failure event was more significant, that is 57% in group 3 patients. And the interesting thing, the receiver operating characteristic curve showed that the cutoff value of paced QRS duration was 165 milliseconds with a sensitivity of 0.7. So here is a graphical presentation which showed the significant reduction of ejection fraction in an apical pacing group whose paced QRS duration is more than 190 milliseconds. In summary, a prolonged paced QRS duration has a detrimental effect on long-term cardiac function during RV apical pacing in patients with complete heart failure. And paced QRS duration could be a useful predictor to identify the patients who are at risk for heart failure. So, studies comparing RV septal with RV apical pacing have been available for more than 2 decades. And here's a study showed RV outflow tract septal pacing is superior to RV apical pacing. So to identify a more favorable pacing strategy with a fewer adverse effects, 80 patients were included and followed up and paced their either right ventricular apical pacing or RVOT septal pacing and followed up for 2 years. The baseline demographic and clinical characteristics are similar, but after 2 years, the final maximum P-wave duration, P-wave dispersion, QRS wave complex duration, and left atrial volume index, the ventricular end systolic diameter, interventricular mechanical delay in the RVOT septal pacing group were significantly less than those in the RVAP group. And final ventricular ejection fraction of the RVOT septal pacing group was significantly higher than the right ventricular apical pacing group. So here we can see the QRS duration in the RVAP group after 2 years follow-up showed initial was 102 and in the final 154. And in the RVOT septal pacing group after 2 years, the duration increased to 130. So in summary, it indicates that RVOT septal pacing maintain more satisfying atrial and ventricular electrophysiology. In conclusion, we can say direct His bundle pacing or parahesian pacing is supposed to be the most physiological pacing site for patients with atrioventricular nodal disease or intrahesian bundle disease, which is technically difficult. And what meta-analysis of randomized control trials have been suggested that the term RV septal pacing be replaced by the broader RV non-apical pacing. The most studied RV non-apical pacing site is for ventricular pacing is ventricular septum, either mid septum or outflow tract septum. So even then, the detrimental effect of long-term RV apical pacing are significant enough to suggest that it is high time to adopt RV non-apical pacing. However, Achieving true ventricular septal pacing is critical for its beneficial effect. So I showed my previous two ECG that one with septal pacing, the QRS duration is about 88 milliseconds, and another with RVOT septal pacing, where the QRS duration is 144 milliseconds. Thank you.
Thank you, Firdausi, for nice presentation. Now it's open for discussion. Ashok.
Yes, thank you, Firdausi. All three cases in different position of RV lead. So you have shown some parameters. I have some query to Rafiq sir and others. Many patients with apical pacing, even single chamber, they are doing well for last 20 years. But many of my patients, dual chamber pacing, distal non-apical distal septal pacing, I have got progressively EAP is decreasing, patient going into the LVF. So other than ECG QRS duration, any other criteria by which we can follow up this patient, which will do better, which will go into the failure, any echo or other parameters that we can assess in subsequent follow-up, sir?
So, I mean, the question is septal. I mean, I have been doing routine septal pacing for many, many years, for at least more than 10 years. The problem is, if you take the total number of patients with normal EF that got apical pacing, majority do fine. The other problem is, I realized that by trying to do septal pacing, I increase my fluoro time by 100%. Because I can put an apical lead in less than a minute, and to put the septal lead, because I just cannot take any septal position. I have to go at a good set, and it will become 3 minutes. So that is one part. So Abiba, can you show us your? I want to look at your slides again. This is a very, but to gain experience, it is important for us to gain it. So nowadays, what we do, if there is borderline impaired LV function, I try to do. Can you go back, please? Keep going back, and I'll tell you when to stop. Yeah, keep going back, please. Back, please. Yes. So this is the third case, right? And this had a wider QRS. If you look at the LAO view, it is pretty high in the septum. And go back to the other case, the one before that. Yeah, go back, please. Look at this one is a little lower. Usually, you have to be careful if you go too high up. Sometimes it is possible that you will screw the LAD. So yes, please watch out for that, because LAD is not too far away from that place. So practicing septal pacing, it takes time, but I think it should be practiced. Number one, and then this ECG that you are showing a narrow QRS, it can also be a pseudofusion. So definitely prove that this is a narrow QRS, you have to pace just the ventricle at a faster rate, because this patient did not have AB conduction problem. So it is also possible that you are just seeing a pseudofusion. So I'm not saying that this is pseudofusion, but to make sure that it is real septal pacing, you have to do just single ventricular pacing at a rate faster than the sinus rate. And you have to map a little bit, but these are very interesting concept to practice. It takes time, and the way to practice it is, in the beginning, you will have a tendency that, well, the septal lead may dislodge. So what you do, if you are starting out, try to put septal lead in patient with 6 sinus syndrome, so that if the A lead works fine, even if the V lead moves a little bit, you are not in trouble. And once you have gained enough experience, then start using it in the complete heart block patients. And that's what I did. In the beginning, I did about 20 to 30 cases of a 6 sinus syndrome patient. And once I mastered the technique, then I said, yes, I'm going to use it on everybody. But also keep in mind about the fluoro time. When you do these cases, a 1 minute fluoro, when you go to 2 minutes, you have increased it by 100%. For you, it's not a good thing to do. But these are good cases. Thank you.
Thank you, sir.
Thank you, sir. Now I would ask Dr. S. Mosaddeq Hossain Sabi to present his case. Adil, please share your screen. Okay.
Mr. Chairman, Professor Rahul, our Chief Guest, Dr. Tawfiq Ahmed, and learned panelists, moderators, and participants. Good morning and evening. I welcome all to my presentation, Learning of Supraventricular Tachycardias from an Avestin patient. A 25 years old man presented with recurrent palpitation and dizziness. He denied syncope. 2 prior radiofrequency ablation were done but failed. Echo showed evidence of Avestin anomaly. See, this is a echo of Avestin anomaly. Here, tricuspid annulus is displaced towards the apex, and right atrium and etiolized right ventricle also hugely enlarged. Effect of valve displacement on conductive system and associated arrhythmias. There occurs separation of valve hinge point from AV node, leading to breaching myocardium and fibrosis. This leads to increased incidence of accessory pathways, interatrial, infranodal, etiolized, RV conduction delay, and there may be right bundle branch block, subtle pre-excitation, longer ER, AB, and VA time at baseline and during tachycardia. And these patients are prone to develop ABRT, ABNRT, AT, atrial flutter, even ventricular tachycardia. This is the baseline ECG showing short PR interval and delta with RS transition at V3, V4 with superior axis. Most likely this is a case of right-sided pathway and it is posterior or posterior origin. And radiography shows usually dilated right atrium with wires in the right coronary artery. Catheter placed in the right ventricular bundle of his and coronary sinus. Baseline ECG was normal intervals. This is retrograde conduction showing non-decremental conduction with eccentric activation pattern with long VA. Possibly this is a case of AP pathway. Retrograde AP showing AB nodal echo beats. As this slide shows two ideas, one is pathway, another is AB nodal disease, possibly ABN RT, as there is 3 echo beats. Retrograde ABN ERP and it is 370. Integrate conduction during right atrium S1 S2 showed non-decremental properties. AP integrate ERP followed by problematical tachycardia, and it is SBT1. And we can see that there is long DA and eccentric activation. ECG during SBT1. Retrograde atrial activation during SBT1 and ventricular pacing shows similar activation pattern. This slide showed his refractory PVC terminate the SBT without A. And this type of finding is pathognomic for ABRT, that is accessory pathways. As SBT1 is non-sustained, we try to induce SBT again, and this causes SBT2 induced after isoprotonol infusion. You see this tracing this tachycardia showing long BA time with concentric activation. Updates so far, SBT1 cycle length 400-8 induced with isoprotonol non-sustained, eccentric activation pattern similar with D pacing. TBC showed termination of the tachycardia without A, and SBT2 show cycle length 322, and it is induced after isoprotonol infusion, and it was concentric activation. So ablation will be done as the finding was clear more for AP, and ablation done with deep pacing. And after ablation, so BA is separated. Now after ablation, ECG is showing comparison, no pre-excitation with RBB.
Hello.
This ECG is before ablation, this is after ablation. This is after ablation, this is before ablation. It is showing that short paired delta and there here. Fluoroscopy of successful ablation site. You see this is the site posteriorly, right attempt posteriorly. Now showing BA conduction of ablation, and it is decremental. Induced previous SBT and showing the decremental properties. Now we tried for BOP, ventricular overdrive testing, Moradi maneuver. So BAV response with PPI minus tachycardia cycle length more than 150 millisecond. You see BAV response and PPI minus tachycardia cycle length more than 115, and also STA minus BA is also more than 85 millisecond, not shown here. This goes in favor of atypical AVNRT, fast slow pathway. And there is also long BA in this slide. This is showing no reset during his refractory pacing. You see, with his refractory pacing, no atrial activation advance. Atrial activation not advanced, but ventricle is little bit advanced, goes in favor of AVNRT. So SBT2 induced after isoprotonol infusion, concentric activation pattern, ventricular overdrive pacing showed DAV response, long PPI minus TCL. His refractory pacing did not advance the A, decremental retrograde activation. So AVNRT likely and proceed to solo pathway ablation. The ablation catheter is small A, large B, solo pathway ablated. Fluoroscopy showing the solo pathway ablation, and after solo pathway ablation, you see BA dissociated, and ultimately BA blocked. rear block. After that, another SBT3 induced after isotonal infusion. The ECG pattern, takeaway pattern is different from the previous two. Here, long DA, takeaway cycle and little bit variable. And one thing is, it is eccentric activation, and earliest activation is CS 9, 10, 7, 8. And if we think this type of takeaway, as we previously ablated the accessory pathway, solo pathway ablated, and DA block. So it is most likely focal atrial tachycardia. And Mr. Algorithm, if we follow, if it is suspected PF, then at B1 upright P goes in favor of right-sided atrial tachycardia, and it is close proximal CS os. This is the SBT3. It is different from first and second SBT. So, tachycardia, cycle length atrial tachycardia induced after isotopic infusion, eccentric atrial activation pattern, and it occurs after DA block. So, it is most likely it is atrial tachycardia. As there is DA block, so we did not do any further maneuver like BOP, AOP, or DA linking, as DA is blocked. So there is a limitation. AT activation mapping, you see in ablation catheter, it is about 40 milliseconds earlier than the surface period. And during ablation, atrial tachycardia terminate without APC, termination without APC. So this goes in favor of atrial tachycardia ablation. Ablation of AT showing the ablation catheter, that's CS, close to CS, okay? Close to CS. This is the 3D mapping showing the ablation site. You know, this is the insect navex, and it is yellow blue, and this is the accessory pathway ablation site. This is solo pathway ablation site, and this is the atrial tachycardia ablation location close to CS. Now I am trying to show the 3 tachycardia at a glance. 1 and 2 seems to be similar, but if you minutely look it, it is not similar. You look at D1 in tachycardia 1 and 2. This at 1 it is wider and it is narrower in 2. And look at 2, 3 AVF. It is different in the 2 tachycardias. And the third tachycardia is quite different. So ultimately, Ebstein anomaly, accessory pathway ablated from posterior tragus annulus, atypical first sole abnormality ablated successfully from low cock area. As in Ebstein anomaly, triangular cock become smaller and solo pathway become closer to CS. And atrial tachycardia successfully ablated from coronary sinus ostium. After ablation, post-ablation ECG, you see no short PR interval delta wave, and during follow-up, patient was bad and no complaint of palpitation. Subsequently, he underwent surgical correction, and during correction, there was no documented supraventricular tachycardia. Now patient is fine. Thank you all for patience, witness, and hearing.
Thank you, Dr. Sadi, for your nice presentation. Now it's open for discussion.
Dr. Sadi.
Otherwise,
Dr. Sadi, very interesting cases and very complex and difficult cases. Abstinent animal is always a difficult cases, and if we study in this case is very challenging, I think. Dr. Sadi, actually, how do you differentiate the third SVT from the, that is what you call the atrial tachycardia, from the sinus tachycardia?
Atrial tachycardia, sinus tachycardia. Sinus tachycardia.
In your case, how did you differentiate it? Intracardia?
PCCG and from the intracardiac ECG. Isn't Sadibhai?
This is intracardiac. In sinus tachycardia and atrial tachycardia, both are long RP tachycardia. Yeah. In sinus tachycardia, in this case, you see you see their earliest activation is CS 910, 7, 8. Yes. In case of sinus tachycardia, this should not. And in case of sinus tachycardia, the activation pattern should go down from SA node to towards, that is atrium, then his, then CS, then RB direction. But in this case, it is not such. And clinically, we can differentiate short warm up period and cool down period, and sinus tachycardia persist long term, then gradually go down.
So, thank you, Dr. Sadibhai. Very complex case. How long?
Yes, I am trying to show that 3 SBT at a time to compare between them. This is our day-to-day practice. It is more common, so I am trying to show in at a time. My idea was to learn from the case.
Again, Dr. Sadi, how did you differentiate the SVT2? That is what you call the AVNRT from the septal pathway in your case?
Yeah. In this case, you know, yeah, we can differentiate the, in case of abstinent anomaly, usually multiple pathways exist. One in the free wall, one maybe in the septal wall. But in this case, we got in the free wall and atypical AVNRT. We can differentiate from the atypical AVNRT from the septal accessory pathway by the, in both cases, we see here post-pacing interval and tachycardia cycle length. If it is corrected, post-pacing interval tachycardia cycle length more than 115 milliseconds, this goes in favor of atypical AVNRT. Also, esteem A minus BA distance is more than 85 milliseconds, then it is atypical AVNRT. If it is less, then it is septal pathway. Another way is also AAC interval during pacing and during tachycardia is also important. If it is more than 40, then it goes in favor of atypical AVNRT. If it is less than 40, then goes it in septal accessory pathway.
Sadi bhai.
Hello. Yes.
আপনি এটা কি 2D দিয়ে করছেন না 3D দিয়ে করছেন?
না না, এটা 2D দিয়ে conventional way failed 2 times. And then with the help of 3D, it was very much helpful, as you know, hugely dilated RA, functional RB. So we can help
3D.
3D
কোথায় করছেন?
It was done in the, I was related with the case in the Jakarta. One doctor did it, I was there, and after that conventional failed, then they did the case in the Taiwan. during fellowship, one doctor took the patient in the Taiwan, and with the help of NSAT NAVEX, they successfully did the case.
Thank you.
Harminto.
Harminto. He was
I have one query to the senior panelist and Rofik sir. Ebstein anomaly is not uncommon, and in our center, I think in other center also, that is the cone procedure some surgeons are doing. In our hospital cone procedure that they are doing regularly, and sometimes this patient having the accessory pathway. Rofik sir, is there any way surgically they can destroy or they can ablate the accessory pathway during surgery of the cone procedure? Because it is very much difficult. Yes, sir.
Sure. Yes, surgical ablation, that's how ablation started. So I remember when we were in Mass General, we will go to the operating room, but you have to take all the electrodes for the mapping. So that is the problem part, that it will increase the surgical time quite a bit. So no surgeon will like it. So if they have SVT, that should be ablated before the surgery. Yes, and even in America, you will not find many surgeons at the moment that will be able to do it during surgery, because most of the surgeons who used to do it are dead by now. But it can be done. But from a surgeon standpoint, they will not like it because it will increase their procedure time quite a bit.
Yes. So anyhow, during procedure, lot of ligation, lot of suturing, and lot of stitches and cutting are during procedure. Incidentally, how frequently that can destroy the accessory path during tricuspid annuloplasty?
Yes. This is a good question. If you didn't want to destroy it, you can destroy it. But if you want to destroy it, it will never happen. This is the problem. But perfect example is when we do AV node reentrant tachycardia, we are always worried about developing complete heart block. But then we had cases of AFib with RVR, and we tried to ablate the AV node, we cannot. So when you want to destroy it, you can't destroy it. So I mean, it's a possibility it can happen, but big chance probably.
Thank you, sir.
Thank you, Rofik sir.
Thank you.
Now I would ask Dr. APM Saurabh Jaman to say some few words and wrap up the session.
Otherwise, screen share.
Okay.
Otherwise, please stop.
In theory, we see that Ebstein anomaly have too many accessory pathways, and this is one of the proof that Ebstein anomaly has got 3 types of tachycardia. So it is always very difficult and bothering for a surgeon, for a electrophysiologist to do a case. In case of Ebstein anomaly, it is very difficult case, and in expert hand also they can fail many times. That Sadi has shown. Thank you.
Thank you, sir. So we are at the end of our case presentation symposium. Now I would ask Dr. Atharhali to say few words, concluding remarks, and give thanks to everybody. Dr. Atharhali.
Thank you, Dr. Jamil. And first of all, our thanks and gratitude to Dr. Rofik Ahmed sir for his presence. And sir, this is the program. Actually, this program is useful and academic only because of you.
Thank you,
sir. And actually, we are inspired from your suggestion that, sir, actually, and this program also inspired our junior electrophysiologists also. So we are committed to arrange these programs at periodical intervals, sir, at 2 months or 3 months like this. And every time we want you, sir, as because without you, this program is actually not successful.
Thank you.
So thank you, sir. And I also like to thank our all presenters for their beautiful presentation and case selection. And Umme Habiba Firdausi, I would like to see an excellent, nice demonstration of your septal pacing and encouraging discussion. And our all panelists, including Ashok Datta, for being your time, and you are still present here. Thank you, Dr. Ashok Datta.
Thank you.
And
স্যার আমি মহসিন স্যার
yes, Mohsin is also here, and
স্যার আমি একটু কথা বলবো স্যার
yes, Mohsin also. Thank you
স্যার
very much.
আমাদের মামুনের প্রেজেন্টেশন ছিল তার কেসটা বাদ দিলেন কেন স্যার
তা তো আমি জানতাম না।
না স্যার এটা প্রত্যেকবার এখানে স্যার তার কেস আগের করার না এবারে বাদ দেন না স্যার
I want to ask that question, Abdul Al Jamil.
স্যার এগুলো ঠিক না স্যার আপনারা যেটা করতেছেন এগুলো ঠিক না স্যার
না 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 এটা প্রথম মিস্টেক হয়েছে মহসিন ভুল বোঝার কোনো কারণ নাই এটা জামিল মামুনের কেসটা হয় নাই আমি তো মামুনের কেসের জন্য অপেক্ষা করতেছি
স্যার
মামুনের কেস আসে নাই তোমার কাছে
মামুনকে নেক্সট সেশনের ফার্স্ট স্পিকার হিসেবে রাখতে পারি
না কিন্তু জামিল তাহলে বাদ পড়লো কেন মামুন তো
অ্যাক্সিডেন্টালি বাদ পড়ে গেছে আমার ঠিক মানে কি করতে পারিনি
অ্যাক্সিডেন্টালি কেন বাদ পড়ে ভাই জামিল ভাই গতবার বাদ দিয়েছেন
আই এম ভেরি মাচ সরি
না না এটা আপনাদের চক্রান্ত আর কিছুই না
না ঠিক আছে মহসিন তুমি রাগ করো না আমি অপেক্ষা করতেছিলাম যে মামুন বলবে তারপর আমরা কনক্লুশনে যাব কিন্তু মামুন বললো না মামুন কি আছে
মামুনকে দেখতে পাই না
আচ্ছা মামুনকে দেখতে মামুন তাহলে প্রেজেন্ট করুক মামুন থাকলে মামুন প্রেজেন্ট করুক
আর ইউ দেয়ার
মামুন থাকলে মামুন প্রেজেন্ট করুক আচ্ছা তাহলে মামুন প্রেজেন্ট করুক মামুন প্রেজেন্ট করুক
সরি আই এম ভেরি মাচ সরি আই এম ভেরি মাচ সরি
আমি অপেক্ষা করছিলাম যে লাস্ট কোর্স হওয়ার পর আমরা কনক্লুশনে যাব
আই এম ভেরি মাচ সরি
মামুন করো মামুন ইউ স্টার্ট ইওর প্রেজেন্টেশন
প্লিজ
yes share your screen and start your presentation
sir am I audible sir
Mohsin bhai
you are audible
we can hear you share your screen
okay so my screen is visible sir
yes we can see you
so honorable chairman respected audience from different part of the world assalamu alaikum and very good day I'm very happy and it is my great pleasure to be present in this program simultaneously it is my audacity to be present in such august and learned gatherings. Especially, I would like to utter the name of Dr. Rafiq Ahmed sir. COVID-19 have created various sorrow and burden for us. Simultaneously, it created some opportunity for us, for which I can join this program from southeastern corner of our country. I am Dr. Al-Mahmoud. My today's case is reducing the ablation of accessory ventricular pathway of a young lady with abstinence anomaly, which is some sorts of similar with previous case. So our patient is 20 years old lady. Actually, her journey was started with us 6 years back when her age was 13 years old. She is a known case of abstinence anomaly with WQW syndrome. She has history of failed ablation for several times. This is the echocardiogram of the patient from which you can easily appreciate the case of abstinence anomaly with carpet classification type B. And from this, from where you can see the about 3 centimeter apical displacement of the septal lift of the tricuspid valve. This is the 12-bed ECG, though it is not so clear, but from this ECG in EP lab, we can easily see the ventricular pre-excitation with the right-sided pathway and probably right posterior septal pathway, though it is difficult to comment in abstinence anomaly. And this is the 12-bed ECG in tachycardia. And she has history of hospitalization for several times. And previously, I mentioned that she has history of failed ablation, and her due to failed ablation, she was kept on different antiarrhythmic drugs like verapamil, sometimes sutalol, sometimes amiodarone. So, for his use burden for tachycardia, decision was taken for review. This is the EGM during sinus rhythm, and this is the 12-20 during tachycardia. So we are dealing with orthotomic AVRT, and this tachycardia was insistent, so very much insistent even in EP lab. As we know, the success rate of ablation in Epstein anomaly is lower than ablation without Epstein anomaly. Due to some anatomic distortion of right heart, there is atrialization right ventricle, and atrioventricular orifice becomes sometimes twice the normal. So localization of the accessory pathway becomes difficult, and ablation becomes challenging. So we to localize the atrioventricular orifice, right coronary artery angiogram was done. As we know that right coronary artery is located in a V group epicardially, which represent the atrioventricular orifice in endocardial. So right coronary artery angiogram was done, and a wire was kept in right coronary artery, and ACT was kept high. This is the EGM during tachycardia, cycle length of which is 340 milliseconds, and we can easily appreciate concentric activation, and mapping was done during tachycardia with the guidance of right coronary artery wire. So after putting in a suitable position, radiofrequency ablation was given, and after certain period, tachycardia stopped. But after this period, again tachycardia started with same cycle length. Then mapping was done, and radiofrequency ablation was given, and tachycardia stopped. This tachycardia, mapping, and radiofrequency ablation was going on again and again. At one point, one operator wanted to give up the procedure, but another operator wants to adamant to see the success of the procedure. So radiofrequency ablation was given for several times, about 8 to 10 times. After a certain period, success was come. Okay. In this slide, in right panel, you can see the fluoroscopic view where mapping was done in LEO view around about 7 o'clock position with the guidance of the right coronary artery catheter. And at that time, the stability of the mapping catheter was very difficult. So a long sheet was used. So another catheter was used to keep the mapping catheter stable. And after a certain period, success was gained. In the meantime, coronary sinus venogram was done when the tachycardia was coming again and again. To see the this venogram was done to see the any coronary sinus diverticulum, but it was not present. This is the program actual stimulation was done to see the success of the procedure, and here you can see the trail stimulation was blocked. And this is the EGM after successful ablation, and this is the 12-body CG after successful ablation. This is the follow-up ECG after 2 months, and this is the follow-up ECG after 8 months, where you can see that there is no ventricular excitation and patient has no complaint of palpitation. So this is all about my case. Especially wants to give thanks Professor Dr. Masud sir, who was the operator, and with the opportunity to present the case. And thank you all for patience here.
Mamun, I'll have to see that last slide. Is it the termination of the no the previous one? Go back. Go back. Is it the termination of the tachycardia? No.
Yes, sir.
Yes. Not the stimulation, because I could not see that in big. Okay. That is the termination of that.
Yes, termination.
Any further discussion by our respected Dr. Rafiq Ahmed sir, because you are too late.
Yeah, no, I think it's an interesting case, but if you look at carefully at the signal in ablation 3 and 413, you can see how early the A is. And that sharp signal, I wonder if this was the retrograde accessory pathway signal, which disappears after when you see the success. Mohsin, any comment on that? Yeah. Yeah. So good.
Mohsin bhai, are you here? Unmute, please.
So anyway, I mean, right-sided accessory pathway as it is very difficult. And when it is abstain, it makes it more difficult because you don't have that typical IVC tricuspid, the annulus, because it has moved. And the stabilization of the catheter is the most difficult part in right side. And these cases can be very long cases. Thank you. Good case.
Thank you, sir.
Machine.
Probably he has left with angry.
Okay, then we must congratulate every presenter, everybody who has taken their time, difficult time, one only in holiday in the morning, because we are doing 6 days work, we are really tired, and at the same time it is less than whatever I say about our dearest Dr. Rafiq Ahmed. So I must not say anything because he is always with us, and it is very difficult for me to express my gratitude to him because we are so proud of him. We are so grateful to him. Sir, it is late night in your case. You will go back to your work tomorrow morning. So
thank you.
We must thank you again, and you please, sir, take rest.
Thank you. Thank you. Ashok, nice seeing you.
Thank you, sir.
And to everybody who has presented their case, who have done these cases, I must congratulate them. They have taken the time, and what we have started in 2004, now we are in a place that we can show our cases to everybody and inspire the young generation to come to this field for when we left with the seniors, myself, Dr. Atar Ali, we leave, and you take the leadership in this section of cardiology, and we'll be seeing it when we leave this world from the heaven. Thank you all.
Thank you, sir. I do apologize to Dr. Al Mamun. Sorry for the mistake. And please convey my message to Dr. Mohsin also. Sir, I have got a proposal for next meeting. Please give the responsibility to Dr. Mohsin to arrange the symposium. Saurabh, sir. Otherwise,
Jamil, I have seen your writing in the chat box.
Yes, sir.
So we'll discuss it. In our next meeting, we'll discuss it, and we have a program for the technicians. In that cases, from your lab, from my lab, from NICVD, from Evercare, from Heart Foundations, we'll ask our technicians to prepare their case. We will help them. Okay, and
okay,
next
sir.
year, next month probably.
Dr. Mamun, please unshare, stop sharing. Yes.
Okay,
sir.
Thank you.
Okay, we'll arrange it, and my discussion is about the final the international conference of 17. I have letter from Dr. Anil Saxena and Dr. Abhishek Deshmukh. They will attend, and I must ask Dr. Atar Ali, Dr. Jamil, Dr. Mohsin, all of us, Hadi, Ashok, Nesar, everybody we are in the senior most, we must work hard to make our next program, that is the international conference, successful. Thank you all.
Thank you, sir.